Hi, let's begin with a fresh system. The next system is excretory system. Clinically important one. Of course, clinically all the systems are important. But why I call this important is also from academic point of view. You get a lot of MCQs from the kidney and renal functions and bladder functions, acid-base balance. So we will go through those topics in the conceptual details. In the kidney, we will discuss introduction, nephron, JJ apparatus, renal circulation, then the clearance concept. Lots of questions have come in the past related to the concept of clearance. Then, of course, GFR, a big topic, factors determining, influencing the GFR, and tubular functions, how the substances are reabsorbed, how sodium and water are handled by various parts of the nephron, and of course, I have not written, but mechanism of concentrated urine formation, that too will be discussed. And then bladder, micturition reflex, cystometrogram, the types of bladder in various lesions. Finally, we will deal with acid-base balance. Why do we discuss acid-base balance in this chapter in the kidney? Because kidney plays a very crucial role in the regulation of pH and the acid-base balance. We will see all that in the due course of our discussion. So let's start with the excretory system, starting with the kidney. And this is an introductory part. So basic structural and functional unit is the nephron, and therefore, although it will be too basic to discuss the parts of the nephron, but still, just as a quick revision, look, renal artery breaks up into arterioles, and then there is afferent arteriole which brings the blood into the glomerulus. Glomerulus is a tuft of capillaries. Here there will be filtration of substances into the Bowman's capsule, and then they will start flowing down the tubules. So we have a proximal convoluted tubule which is proximal to the glomerulus, and the proximal straight tubule after that. Then we have the loop of Henle, the descending limb and the ascending limb. The ascending limb has a thin portion first, followed by the thick ascending limb, thick wall. So that will be called as thick ascending limb of loop of Henle, which will then lead to the distal part of the nephron. Now the distal nephron starts. So distal convoluted tubule, and then a connecting tubule, which will then finally lead into the collecting duct. Final urine formation will happen in the collecting duct. Final pH of the urine, final osmolarity of the urine, all of that will be decided in the collecting duct. And then the ducts from various nephrons, they join to form a duct of Bellini, and then finally these ducts, now the urine has been formed, so it will be drained up to the pelvic calyceal system, and from there, of course, it will be drained into the down the ureter to enter the bladder. So that's how it happens. Let me also add one point here, although we will discuss it in detail later on. But you know, a very interesting type of example for the functioning of the kidneys. Interesting one. How there are these three steps in the urine formation that can be seen. Glomerular filtration, then tubular reabsorption and tubular secretion. Three steps in the urine formation. You know, the example is something like this. Suppose we have to set up a cupboard. There are a few things already there in the cupboard, the books and the other stuff, and we want to clean it up. So what do? We will first take out everything from the cupboard, everything, and then whatever is required will be put back, whatever is not required will be discarded. If you want to add something, that will be also added, and then cupboard will be set up again completely. I had read that example somewhere. So somewhat similar is happening here, that in the glomerular filtration, everything is filtered out except of course the proteins in the plasma and the cells. So these two things are not filtered, but otherwise everything is filtered out, and then whatever is required by the body will be reabsorbed. It will be taken back into the blood. Whatever was not required will be secreted by the tubule. Look, glomerular filtration cannot remove the substance entirely. So we have secretion. Substances will be secreted into the tubules. And finally then all of this will go on happening in different parts of the nephron. Final processing will happen in the collecting duct and the urine will be formed. So, you know, if I were to say what is the urine composition, I mean, it is made up of what? Or what are the processes? So, the processes or the concentration of substances or the final urine composition is equal to glomerular filtration plus tubular secretion minus the tubular reabsorption. Isn't it? The filtration and the secretion, these two processes are basically to eliminate the substances into the urine. So it is taken into one bracket, minus the substances that were reabsorbed. I mean, that's not coming into the urine, that is taken back into the blood. This is how urine formation takes place by these three steps or processes. And that was the most basic part. Now let's see the types of nephron. Each kidney is made up of about 1 million nephrons. So let's see the types of nephron. Now if you look at the structure of the kidney, it has two parts. There's the renal cortex, the outer part, and renal medulla, that's the inner part. And therefore there are two types of nephrons. First type is the cortical nephrons. Cortical nephrons, and please take it as a representative diagram. So cortical nephrons are something like this. They are glomeruli and then the loops. So 85% nephrons are cortical nephrons. So majority of the population. They have short loops. They have short loops, you can see there. And what is their function? They will form the normotonic urine. I mean, to concentrate or dilute the urine is not the function of these nephrons. They will only excrete the substances in a normotonic urine. The second type of nephron, which is more important, of course everything is important, but otherwise functioning wise you should look at the other type, which is juxtamedullary nephron. The juxtamedullary nephron, about 15% population is that of juxtamedullary nephrons. Their glomeruli are located at the junction of cortex and medulla, for which reason it's called as juxtamedullary. It's in juxtaposition with the medulla, as we will see here. So glomeruli are located at the junction of the cortex and medulla, and they have long loops. Should be understood, they have long loops which come all the way into the inner medulla. So let's write it down. Juxtamedullary nephron has long loop, and the most important part is that the concentrated urine is formed by these 15% nephrons. hypertonic urine, formation of a hypertonic urine is the function of these 15% juxtamedullary nephrons, right? So these two populations of nephrons can be seen in the kidney. But if you have noted, all the glomeruli are essentially located in the cortex only. Right. Let's just add one more point in this about the renal blood flow. Renal blood flow. You know, if you compare the cortex and medulla, this is a comparison of renal cortex and renal medulla. Most of the blood flow goes to the cortex. Maximum, majority fraction goes to the cortex, which is quite easy to understand because all the glomeruli are situated in the cortex. If you see the fraction wise, greatest fraction is in the cortex and small fraction in the medulla. The blood flow comparison. But oxygen consumption, if you were to compare the oxygen consumption of cortex and medulla, what do you find? Oxygen consumption is slightly greater in the medulla as compared to the cortex. Not a big difference, but some difference is there, and medulla or consumption of oxygen in the medulla is greater as compared to cortex. The question is, why is that? Okay, note this point that the oxygen consumption in the kidney, or let's say ATP breakdown or metabolic rate in the kidney, is directly linked to or directly proportional to the tubular load for sodium reabsorption. So that's one point that should be clearly understood. The metabolic rate in the kidney is directly linked to the tubular load for sodium reabsorption. Now, why is that? Look, sodium reabsorption in various places occurs in different ways. There are different mechanisms by which sodium reabsorption happens. But in the loop of Henle, in the juxtamedullary nephrons, you know, if these are the cells lining the tubules, say in the thick ascending limb of loop of Henle. So if I just draw a bigger diagram over here, then the cell, the lining cell, has an apical membrane and the basolateral membrane. Basolateral membrane is facing the blood vessel. The apical membrane has a transporter like NKCC or NCC, and the basolateral membrane facing the blood vessel, there is a sodium potassium pump. So by secondary active transport, co-transport, the sodium will come in, and then sodium potassium pump will drive the sodium out of the cell into the blood. This is a simplistic model, just to understand it easily. Actually, it's the other way around, meaning that first the sodium potassium pump at the basolateral membrane will take the sodium out of the cell. So sodium concentration inside the cell will decrease, and then a concentration gradient got created from the lumen up to the cell, and this concentration gradient will be utilized, and the sodium will be transported, and also the potassium and chloride or whatever is the transporter on this side of the membrane. There is ENaC at some places, there is NKCC, NCC. That's the sodium reabsorption. Now, you know, 2/3 of the sodium reabsorption occurs in the PCT, We will see that later. But just I'm making a little clarification because I get this question from students all the time. That PCT reabsorbs 2/3 of the filtered sodium, and that should be a great energy consumption. But no, mark this point, that in the PCT and in the other places, sodium reabsorption occurs by other mechanisms, paracellular mechanism. Look, if the sodium is transported like this across the cell, then that's a transcellular mechanism across the cell. But there can be a paracellular mechanism also between the cells. By paracellular mechanism or by electrochemical gradient, the sodium is driven out, and it is driven, its movement is driven. Those mechanisms consume less metabolic energy, and particularly these mechanisms where on the basolateral membrane there is sodium potassium pump, which is an ATPase, and on the apical membrane there is NKCC or NCC, they will consume more amount of metabolic energy. And because these transporters are located in the loop of Henle, long loops of Henle in the medulla, therefore there will be a greater metabolic energy consumption in the medulla as compared to cortex. There is not a big difference between the two, cortex and medulla, so far as the oxygen consumption is concerned. But if you were asked this question, then remember this: medulla will consume more oxygen relatively. It will have a slightly greater ATP consumption or breakdown. That was the first part related to the introduction. Now let's stay with the nephron and let's talk about a part of the nephron, that is JG apparatus. JG apparatus. You know, we are slowly moving towards the next pattern. Previously there was AIPGE, All India PG entrance exam. Then there was NEET. Now we are moving towards the next pattern. And in the next pattern, majority of the questions are likely to be problem solving type or clinical case type. But previously there used to be a lot of direct questions, one-liner type. One such question was, which of the following is the name of this cell? Alternate name. Well, first of all, how is it pronounced? I'll try my best. It's called as Gumati cell. What is this cell? That's the question. And the options are the macula densa cell, the Lassis cell, the granular JG cell, or type 1 cortical interstitial cell. You want to take a guess? Okay. The Lassis cell in the JG apparatus is known by this name as well, because this is the name of the discoverer who discovered this JG apparatus and that particular cell. Therefore, just remember it. Okay, so JG apparatus. There is one more question. I remember it was asked in 2012 or something. The question was, the JG apparatus lies in close relation to, okay, and the options given were afferent arteriole, early DCT, collecting duct, or glomerulus. And I tell you, more than 80% students gave wrong answer to this question. Most of them gave the answer as early DCT, but that's not correct. The answer is actually, hold your thoughts, answer is coming up in 2 minutes. What is JG apparatus? Look, for every nephron, here is the structure of the nephron. For each nephron, what happens is, its afferent arteriole and early part of DCT, thick ascending limb of loop of Henle and the early DCT. These two parts, they come close near the glomerulus. So they will come close to each other near the glomerulus, forming a complex of cells which is called as JG apparatus. Okay, and so there are three cells in this complex. First, the cell in the wall of the afferent arteriole, the cell in the wall of the afferent arteriole. Second, the cell in the early DCT, so that cell which is lining the early part of DCT, and the third cell is between these two cells, between these two parts, the afferent arteriole and the tubule, the early distal tubule. The third cell between these two. So these three cells, okay, afferent arteriole, early DCT, and the cell between these two. And therefore this makes a complex. What is the advantage of this kind of a complex is that there is an easy signaling that is possible from the early DCT up to the afferent arteriole due to the presence of such kind of a complex. Because now the distal part of nephron is beginning. When early DCT comes, now the distal part of the nephron is starting, and that means now finally the urine is going to be formed. So there is a likelihood that suppose a lot of sodium has reached this part, then the sodium might be lost into the urine, and that's not what we desire. That's not what is desirable, I mean to say. And therefore, it will send the signal to the afferent arteriole and make the required changes, as we will say. And therefore, this mechanism is made easy by such kind of a complex of cells. Okay, so that's the significance of the JG apparatus. Let's see the cells in the JG apparatus. First, the granular, or also called as JG cell, which is in the afferent arteriole. Granular or JG cell. What is its function? It synthesizes the enzyme renin, actually prorenin, which then forms the renin. So what is the importance of this? This is involved in regulation of blood volume and blood pressure. We have done this in the CVS, so I'll just avoid the repetition. That if there is a decrease in blood volume and therefore there is a decrease in blood pressure, then there are volume sensors and baroreceptors present in the renal artery. They will sense it, and then these cells will release renin. There will be something called as PRA, plasma renin activity. It will increase, and what happens as a result? It will convert angiotensinogen into angiotensin 1, and then while it is passing through the lungs, there will be angiotensin 2, and angiotensin 2 will cause release of aldosterone. So that is the significance of RAAS, renin angiotensin aldosterone system. So that's the first function of the component of the JG apparatus, regulation of blood volume and blood pressure. I would urge you to refer to the chapter on CVS, regulation of blood pressure, so that you can correlate this renin angiotensin aldosterone system. Second cell is the cell lining the early DCT. Many authors believe that it is in the later part of the thick ascending limb. So thick ascending limb is ending and the early part of DCT is starting. The cell is located there. And it is called as the macula densa. Now, what is the function of this cell? This is the major component, and the main function of the JG apparatus is performed by this cell. By the way, the question that I asked you, the JG apparatus lies in close relation to? And the options given are the afferent arteriole, early DCT, collecting duct and glomerulus. These four were the options, and majority of the students gave the answer early DCT because thinking that macula densa is the major component, so maybe. No, the answer is glomerulus because the name is juxtaglomerular apparatus. Why is that? That's because it is in juxtaposition to the glomerulus. Many students forgot this and they gave the wrong answer. So let's come back to this. Macula densa, the cell lining the early DCT. What is the function of macula densa? Sensing of sodium and also chloride actually in the tubular fluids reaching the early DCT. Sensing of sodium and chloride in the tubular fluids that are reaching the early DCT. And then what it does is to initiate the tubuloglomerular feedback. Tubuloglomerular feedback, very important mechanism for the body physiology, very important mechanism. Why do I call it important? See here, let me explain this mechanism in detail. You know, we the human beings are facing lots of situations on a daily basis and on a moment to moment, minute to minute basis, whereby the blood pressure keeps on changing. I mean, change of posture, exercise, stress. The blood pressure keeps on changing so frequently. Therefore, the renal perfusion pressure will also keep changing. It can change. Of course, there is auto-regulation of blood flow in the kidney. That should not be forgotten. Yet, there is a possibility that if there is increased systemic blood pressure and therefore there is increased renal blood flow by any such reason, that the blood pressure has got altered and therefore there is increased renal blood flow. Well, increased renal blood flow will mean increased GFR. I mean, that should be obvious, and we will discuss about it later when we discuss the glomerular filtration rate. But more the blood coming into the kidneys, more the blood coming into the glomerulus, more will be the filtration at the glomerulus. So GFR increases, and if the GFR increases, there will be increased filtration of sodium. And if there is increased filtration of sodium, it will be reabsorbed from the PCT. But imagine that there's increased flow of tubular fluids and lot of sodium has got filtered and it has come to the distal nephron. Now there is a real possibility that this sodium might be lost into the urine because it could not be adequately reabsorbed. Sodium will be lost means water also will be lost. So we are looking at a possible fluid and electrolyte disturbance. Yes, there is a possibility of sodium loss, water loss, and resulting in fluid and electrolyte abnormality or disturbance. Can you imagine this? I mean, why did I say it's a very important feedback mechanism? Is because just by change of posture and change of blood pressure, if this were to happen, we could not survive. It will be a complete disaster for the body. But thankfully, we have a mechanism which is in the form of tubuloglomerular feedback. That means from the tubule to the glomerulus, a signal is being sent and this disturbance will be prevented. That's the tubuloglomerular feedback. How is it prevented? Look, as I mentioned just now, sodium is reaching the early DCT. Okay. Now these macula densa cells, they are going to be responsible for tubuloglomerular feedback. How do they achieve this? Let's say here is a macula densa cell in the early DCT. Now sodium has reached in excess amounts in this part of the nephron, and I already mentioned that sodium reabsorption occurs by two steps. This sodium has to be first from the tubule, from the lumen, it has to enter the cell lining the tubule. There are transporters NKCC or NCC, and then on the basolateral membrane there is sodium potassium pump, right? Sodium potassium pump, which will then take the sodium from inside the cell, and finally sodium gets reabsorbed into the blood. Now we are looking at that tubuloglomerular feedback. How will it be initiated? So when there is increased tubular sodium, it will be sensed by macula densa cell. As we have already mentioned, that's the function of macula densa, sensing of sodium. And then sodium reabsorption, as it goes on happening, increasing amounts of sodium reabsorption. That means increased activity of sodium potassium pump, right? Increased activity of sodium potassium ATPase means what? Increased breakdown of ATP. So increased sodium reabsorption, meaning increased ATP breakdown by virtue of activity of the sodium potassium ATPase. Increased ATP breakdown means what remains? ADP, AMP, and finally adenosine. So there is increased formation of adenosine, and this adenosine is the important ligand in the tubuloglomerular feedback. So tomorrow they can ask you, what is the ligand involved in tubuloglomerular feedback? One ligand is adenosine. Now this adenosine, which is formed here during the reabsorption of sodium and the ATP breakdown, this adenosine will go to the afferent arteriole and it will cause constriction of the afferent arteriole. Adenosine will cause constriction of the afferent arteriole, means blood flow to the glomerulus will decrease, and therefore GFR and sodium filtration will also decrease. That was the demand, because sodium was otherwise it was going to be lost into the urine. So adenosine is one important ligand for this. I want you to understand one point. Adenosine is a vasodilator everywhere in the body, but in the kidney, in the renal circulation, it acts as a vasoconstrictor. Please make a note of this. Adenosine is a vasodilator, and it's an important vasodilator everywhere in the body. Let me just quickly tell you that, for instance, suppose myocardial metabolic rate has increased and it needs more blood flow in the coronaries. What happens is there is quick ATP breakdown because metabolic rate has increased. ATP will be converted to ADP, then AMP, finally adenosine, is formed, that adenosine leaks out of the cells and it will dilate the blood vessels, coronary vessels. So blood flow will increase that into that part. This is based on the Bernays hypothesis. So that's how blood flow can increase to the part. But in the kidney, it leads to vasoconstriction. And that's obviously because we have two types of receptors, A1 and A2. So, generally the A2 receptors elsewhere, and in the kidney, there is other receptor. So, adenosine is the one ligand. The other one is ATP. The other signal is generated by the ATP itself. We know that the ATP is a neurotransmitter. It acts like a neurotransmitter or a ligand. So here it's acting as a ligand, and ATP acting via its receptors called as P2X. These are purinergic receptors. These are called as purinergic receptors. So purinergic receptor of the adenosine triphosphate, and therefore even ATP can initiate this tubuloglomerular feedback, and the effect is constriction of the afferent arteriole. So less blood will come into the glomerulus, and therefore less glomerular filtration rate and less filtration of sodium. So sodium will come less and less into the tubules. That is how loss of sodium and fluid and electrolyte imbalance will be prevented. That is the function of tubuloglomerular feedback. So as I said, very, very important mechanism. Well, we have another defense mechanism which I need to explain just at this point, and that is glomerulotubular balance, because very often the students tend to kind of mix up these two things. Tubuloglomerular feedback, which we saw just now to prevent the fluid and electrolyte imbalance, and glomerulotubular balance is another defense mechanism. So let's understand it. The first one, TG feedback, was from tubule to the glomerulus, and here it's like a forward mechanism, glomerulotubular balance. Okay, let me just explain. This glomerulotubular balance is not a part of JG apparatus that we are discussing. Okay, I need to just add it here so that you have a clarity. So I'm writing it on the side of the page. Okay, glomerulotubular balance, what is it? Suppose more blood comes into the glomerulus via the afferent arteriole. More blood has come in, and therefore glomerular filtration rate has increased. More filter has been, more sodium has been filtered and more water has been filtered, and there is a chance of sodium and water loss into the urine. So fluid and electrolyte imbalance, there is a possibility of that. We saw that there is one defense mechanism in the form of tubuloglomerular feedback. There is one more defense mechanism to prevent that water loss and the sodium loss, glomerulotubular balance. You know how it works? Look, suppose a lot of blood flow has come into the glomerulus, which means what? There is increased GFR and increased filtration of sodium and water. Now look at this carefully. Since a lot of water has got filtered out into the Bowman's capsule and therefore in the tubules, the remaining blood in the glomerulus will have a relatively high concentration of proteins. Do you get this point? High concentration of proteins. because proteins are not filtered at the glomerulus under normal circumstances. We will just take the glomerular filtration barrier after this, so even better clarity on this. But proteins are anionic and they are macromolecules, so they don't get filtered at the glomerulus. Now imagine a lot of water has been filtered out from the blood. So the remaining blood that goes into the efferent arteriole has got a high concentration of proteins, obviously. So imagine that the PCT has lot of sodium and water which was filtered, and the efferent arteriole which came out of the glomerulus now has a high concentration of proteins. Now this blood from the efferent arteriole, it will come to the peritubular capillaries. Around the tubule there will be peritubular capillaries. Now this blood in the peritubular capillaries will have a high concentration of proteins. We have seen that. That means it will have an increased plasma colloid oncotic pressure. You will have to refer to the discussion in the CVS which is related to the Starling's equilibrium. The proteins exert what is called as colloid oncotic pressure or colloid osmotic pressure. And colloid oncotic pressure is a force or pressure that pulls the water towards it by osmosis. So we have a situation where the peritubular capillaries have high protein concentration and therefore higher plasma colloid oncotic pressure. And as I mentioned, here is a force that pulls the water towards it by osmosis. So that excess water that has got filtered out, that will be taken back into the peritubular capillaries. And if you know, there is a mechanism called as bulk flow or solvent drag. Look, normally wherever there is high sodium, water follows it through the semi-permeable membrane and we call it osmosis. Here water will move in bulk and sodium will be dragged, and that's called as solvent drag, water being the solvent. So water and therefore sodium can be taken back into the blood, into the peritubular capillaries. So excess sodium and water do not reach the distal part of the nephron and not get lost into the urine. That's called as glomerulotubular balance. So why it's called as glomerulotubular? Because there was something happening in the glomerulus as an extra blood flow and extra filtration that was checked by the tubule. Okay, so glomerulotubular balance and the TG feedback are two different things. I hope you have taken the difference between the two. So come back to the discussion. We were actually talking about the JG apparatus. We saw the first cell in the afferent arteriole, which is granular or JG cell, synthesizes renin. We saw the second cell, macula densa cell, lining the early DCT, and its function is TG feedback, tubuloglomerular feedback. The third cell is between these two cells, between the afferent arteriole and early DCT. So since it's outside the blood vessel, it's called as and outside the glomerulus, so extraglomerular cell or mesangial cell. It's called mesangial cell. This is also called as Lassie cell, the Lassie cell, or I have mentioned this name already, GOOR MAGH TIGH cell, Gomati cell. Yes, we very often we tend to pronounce each letter in the word, but that's not how most of the words are pronounced. Okay. Now this, what is the function of this cell? This also is involved in the TG feedback. it can alter the vessel diameter of the afferent arteriole, and this is also involved in the immune mechanisms related to the JG apparatus. You will learn this in pathology about the MPGN, RPGN, glomerular nephritis, where immune complex formation, immune complex deposition, this cell is involved. Anyways, but that's the Lassie cell. Right, these were the components of the JG apparatus. Now fine, I need to explain just one more cell which is not a part of it. Type 1 cortical interstitial cell. Around the peritubular capillaries in the renal cortex, around the peritubular capillaries but outside the nephron, there is this interstitial cell, so it's called as cortical interstitial cell. This cell synthesizes erythropoietin. It's not a part of JG apparatus, so don't confuse. JG apparatus had 3 cells. We are done with that part. I'm just adding it as an additional information. Erythropoietin is synthesized and secreted by this particular cell. It has oxygen sensor, just as the carotid bodies, chemoreceptors have oxygen sensors, the O2 sensitive potassium channels, just as pulmonary vascular smooth muscle cells have oxygen sensors, hypoxia sensors, O2 sensitive potassium channels. So even here, because then it has to sense the hypoxia and then release the erythropoietin. So erythropoietin is synthesized by the kidney, but from where? From here. Right, so that was another component of the nephron. Before we proceed any further, I just mentioned to you some time back that we will see the glomerular filtration barrier. We will discuss it again in the context of GFR. But since we are still in the introductory part, let's just quickly go through it. Look, the structure of the glomerulus. Glomerulus is a tuft of capillaries. Fine. The blood comes into the glomerulus via afferent arteriole, and then the glomerular capillaries will filter the substances. But some of the substances cannot be filtered out from these capillaries into the Bowman's capsule. So, which substances do not get filtered at the glomerulus? And why is that? Well, that is because of the so-called filtration barrier. Filtration barrier. Let's therefore see the filtration barrier. Here is a glomerulus. Here is a glomerular capillary. Again, a diagrammatic representation. Glomerular capillary. Well, there is outside these capillaries, there are epithelial cells which are called as podocytes. So here are the podocytes, and they have certain foot processes. You'll see that these are the foot processes of the podocytes. Okay. So basically we will have 3 components that constitute the glomerular filtration barrier. It will create a barrier for the filtration of substances. Those substances will not be filtered out. Therefore, let's make this part enlarged. Just a small part of the glomerular capillary and outside will be enlarged. Here is a capillary. First part of the filtration barrier is the endothelial lining of these capillaries. As you can see, the blood vessels are lined with the endothelial cells. So, endothelial lining of the capillaries. The second component is the basement membrane. The basement membrane and all its glycocalyx and all the components. And then outside this basement membrane, there are those podocytes, the epithelial cells, the podocytes. Okay. So blood will come into the capillary, glomerular capillary. Now the filtration will start, but there is a barrier. Endothelial cell, the basement membrane. Let me add, basement membrane and that glycocalyx has the negative charges. So please keep this in mind. The basement membrane has the negative charges, right? And then outside that there will be those podocytes with their food processes. There is also the slit diaphragm. So let me just show it diagrammatically. The slit diaphragm. Components of the slit diaphragm include the nephrin, the podocin, and other such components. So now the filtration will occur through these pores in the capillary basement membrane. Filtration will occur like this. The substances will be filtered out. But one thing, cells do not get filtered. Okay, so that's out of question. Plasma is supposed to be filtered. Okay. Now in the plasma, what all substances are not filtered? The proteins. And therefore, proteins, why don't they get filtered is because of two reasons. One is proteins are anionic and proteins are large molecules, macromolecules. So remember, because they are anionic, they will be repelled by those negative charges on the basement membrane. So they will not be attracted, they will not be pulled for filtration. They will be repelled and they will go in the efferent arteriole. That is what we saw just now in the glomerular tubular balance. So that's one. And the second is large molecules. Large molecules are not able to cross these pores and the filtration slit diaphragm. So please remember, anionic macromolecules are the last one to be filtered. I mean, they will not be filtered at all. Micromolecules and cationic molecules, they are filtered rapidly. So keep this in mind. That's how the proteins are not filtered, because of this filtration barrier. So that's one thing that I wanted to add in the context of the filtration and the filtration barrier. You will learn, like for example, nephrotic syndrome. Nephrotic syndrome is going to be resulting from damage to this filtration slit diaphragm. I told you just now there are certain proteins like nephrin, podocin, etc. So they are damaged, and therefore what happens is the proteins do get filtered out and proteins are lost into the urine. I mean, those proteins are damaged plus the negative charges, but there is a damage to the basement membrane as well. And therefore proteins do get filtered out and lost into the urine in the conditions such as nephrotic syndrome. But otherwise, normally they don't get filtered because of this reason. Right. So that was the introductory part related to the nephron. Now the next part is we will see the renal circulation, and that will finish our first section of the kidney discussion. Let's see the renal circulation. I'm not going to describe the anatomy of it. Already, you know, if I were to speak of the anatomy from anterior to posterior, how the things enter or leave. If this is the kidney, there's artery that goes in, vein that comes out, and there's ureter that comes out. So How they are situated anterior to posterior is the renal vein, then artery and ureter. Vein, artery, ureter. Vein, artery, ureter. Their anatomical relation from anterior to posterior. And then renal artery, then it enters and then breaks into arterioles. Then there are afferent arterioles. Then glomerular capillaries and efferent arteriole that breaks into peritubular capillaries. So, and for just I'll add one more thing. In the case of those long loops of the juxtamedullary nephrons, the blood vessels called as vasa recta with similar long loops are present in the medulla. We will discuss about them later when we discuss concentration of urine. So, in the renal circulation, we are going to discuss functional peculiarities of renal circulation. Let's see. First, renal circulation shows auto-regulation of blood flow. Three vital organs, brain, heart, kidney, they will show auto-regulation of blood flow. So, kidney shows auto-regulation of blood flow. Second point, this is the only circulation where capillaries lead to arterioles. Capillaries lead to arterioles, isn't it? Glomerular capillaries lead to efferent arteriole. That's exceptional because everywhere else in the body, arterioles lead to capillary and capillary leads to veins, venous compartment. But that does not happen here, at least in the glomerulus, in the nephron part. Okay, next, very high blood flow. That again is a very peculiar feature. Kidneys have exceptional amount of blood flow. It's about 22 to 25% of the cardiac output. So that will be second best. Highest is the liver. We've seen that already. Liver is 25 to 27% of the cardiac output. But kidney weighs only 1 to 2% in the body and it receives 25% of the cardiac output. So it's a disproportionately high fraction of the cardiac output, right? Remember this in the next exam also. In any entrance exam, whether it's next or whether any type of exam, physiology also bears disproportionately higher amount of importance. Why? Because direct questions will be there from physiology. That apart, every other subject of the clinical importance will need understanding of physiology. So, don't take it as just, okay, a few questions likely to be asked. No, if you want to answer the medicine questions, you better understand the physiology behind it. Otherwise, problem solving questions become a problem. But I'm sure with these videos, that problem is sorted. Don't you worry at all. Okay, so coming back to the topic at hand, 22 to 25% of the cardiac output, very high. Just 2% of the weight of the body and 25% of cardiac output. Also, blood flow per 100 gram of tissue per minute. That also is very high. Now, naturally, because small organ and massive blood supply. So, 400 ml per 100 gram of tissue per minute. That's the blood flow per 100 gram of tissue per minute in the kidney. That is also second best. If you recall, if you have done CVS by now, tell me which is the first. Carotid body. Yes, carotid body receives 2000 ml per 100 gram of tissue per minute. So please remember, if they ask you which tissue in the body receives maximum blood flow per 100 gram of tissue, the answer would be carotid body. But if they ask you Which organ receives maximum amount of blood flow per 100 gram per minute? Organ, kidney. Tissue, carotid body. Okay, but anyways, the point was very high blood flow among the top two in the body. Next point. Capillary hydrostatic pressure. Capillary hydrostatic pressure. If you remember, elsewhere in the body, in the systemic circulation, please recall the CVS chapter, we have seen this, that at the start of the capillaries the pressure is 30 mm of Hg, by the end of the capillaries the pressure is 10 mm of Hg, and therefore average capillary pressure is 15 to 20 mm of Hg. Right? That's the average capillary pressure elsewhere in the body. In the kidney, the pressure in the glomerular capillaries is 3 to 4 times this pressure. 3 to 4 times. So, capillary hydrostatic pressure is highest in the body in the glomerular capillaries. How much is it? Look, different figures are given in different books. It is 60 mm of Hg. So, just remember like this, elsewhere it is 15 to 20, but in the glomerular capillaries, it's 3 to 4 times that pressure. So, it's 60. And why is that? The reason is also very obvious, because afferent arteriole is little wide and the efferent arteriole, which takes the blood out of the glomerulus, that is little narrow. So, the amount of blood coming into the glomerulus per unit time, does not all of it leave the glomerulus per unit time. Which means what? Which means the blood accumulates in the glomerular capillaries. And you remember we have discussed the Starling's equilibrium when I told you that greater the amount of fluid accumulated, greater is the hydrostatic pressure. Okay. So therefore, it's highest in the body, the hydrostatic pressure is in the glomerular capillaries. Fifth point. Capillary filtration coefficient. Capillary filtration coefficient. You know, everywhere in the body, the capillaries filter out the substances, water and the substances. And this occurs with a certain rate. And that rate of filtration is called as capillary filtration coefficient. This also is highest in the body in the glomerular capillaries. So another highest thing. How much is it? It is 12.5 ml per minute per mm of Hg. Very, very high. Elsewhere it's just in less than 1 ml per minute per mm of Hg in the systemic capillaries, in the tissues. Here it's very high. Alright. So 12.5 ml per minute per mm of Hg. I need you to remember this, because when we start the discussion on GFR, I am going to ask you this once again to recall this. I will answer it, but then remember this. 12.5 ml per minute. So you know how to read the coefficients. Okay. For every 1 mm of Hg of filtration pressure, in 1 minute, 12.5 ml fluid is formed at the glomerulus, means 12.5 ml filtrate is formed by the glomerular capillaries. I mean, if the filtration pressure is 2 mm of Hg, then in 1 minute 25 ml filtrate will be formed at the glomerulus. That's how you read it. Then next, sixth, arteriovenous oxygen difference. arteriovenous oxygen difference. This is least in the kidneys. Least 12.5%. So what is this arteriovenous oxygen difference? Look, elsewhere in the body, when 20 ml of oxygen is carried by every 100 ml of arterial blood, we have done this in the respiratory system as well. When this blood goes into the tissues, out of this 20 ml, generally the tissues extract 5 ml of oxygen. Which means what? Which means the remaining 15 ml goes back into the venous blood. And so, arteriovenous oxygen difference is 5 ml. 20, 15, 5. So, 5 out of 20. 5 on 20 is 25%. That's the AVO2 difference elsewhere in the body. Okay, this is 75% in the case of heart, so highest there. We have done this in the coronary circulation, and this is least in the kidney. It is just 10 to 12.5%, least in the kidney. The reason is also obvious. The reason is small organ but massive blood supply. So massive oxygen is coming in, and therefore whatever it takes out, it will be less percent only in the context of the blood that is coming in. We saw that already, 2% weight and 25% cardiac output going into it. And so how much soever oxygen it extracts, it will be less in the context of that massive blood flow and massive oxygen delivery. And therefore it's the least in the kidney, 10 to 12.5%. Right. So another unique feature in the kidney. 7th, another unique feature. This will be the last one. Elsewhere in the body, now listen to this part, again very amazing. Elsewhere in the body, metabolic rate in that organ or tissue regulates blood flow to that tissue or organ, right? Increased metabolic rate. I told you some time back about the Bernays hypothesis. We saw Bernays hypothesis. Increased metabolic rate, increased ATP breakdown, so increased adenosine formation, and that will dilate the vessels, the blood flow will increase. So metabolic rate regulates the blood flow to that organ. Only two exceptions. One is the skin, cutaneous circulation. Cutaneous circulation is not regulated by the metabolic rate of the skin. It is regulated by the temperature. The primary regulator of cutaneous blood flow is the temperature, ambient temperature. And the second exception is kidney. In the kidney, it is exactly opposite. In the kidney, blood flow regulates the metabolic rate. Do you get the point? Elsewhere, metabolic rate regulates the blood flow. The kidney is exactly opposite. Blood flow regulates the metabolic rate. How? Very obvious. Increased blood flow means increased GFR. Increased GFR means increased sodium filtration at the glomerulus, which means increased tubular load for sodium reabsorption. Increased tubular load for sodium reabsorption, isn't it? And you saw, we have already seen this some time back, that the metabolic rate is directly linked to what? Is directly linked to the rate of sodium reabsorption. So increased tubular load for sodium reabsorption means there will be increased metabolic rate. So please remember, the metabolic rate, oxygen consumption, ATP breakdown is regulated by the blood flow. Okay, elsewhere it's the other way around. Metabolic rate of the organ regulates the blood flow to that organ. The kidney, blood flow to the kidney regulates the metabolic rate in the kidney. Very exceptional, right? So these were the peculiarities of the renal circulation. That was the first section on the excretory system. Now we will describe the mechanisms in detail in the discussion to follow. For example, clearance and GFR and all such mechanisms. We have discussed the first section in excretory system, and that is the renal circulation and JJ apparatus, nephron. Now we'll see the major section, which has the conceptual discussion involved. Let's begin with the first part, a small concept, and that's clearance. The questions that have come from this small section, the clearance. For example, in the clearance equation UV upon P, what is U? That's a question. And the options given are urinary concentration of a substance in milligram percent, or urinary concentration of a substance in milligram per ml, or urinary concentration of a substance in ml per minute, or urine volume, urine flow rate. So what is U and what is the unit for it? That's a question which has been asked. So let's understand the concept of clearance. Basically, it's defined as, now look at the definition. It's a slightly convoluted definition. It says clearance is the theoretical volume of plasma or notional volume of plasma or hypothetical volume of plasma that is completely cleared of a substance per unit time. That's the definition. Now what does it mean really? It means a kidney will take 1 liter plasma and completely remove a substance from it, that particular substance. Then it takes the next 1 liter of plasma and completely remove that substance from it. So that is the definition. Now let's put it simplistically. Clearance equation is UV upon P, just as we mentioned. So a substance is present in the plasma, and therefore plasma is in the denominator, and how much of it comes into the urine per unit time, that's in the numerator, U into V. That is basically the clearance. Means substance is present in the plasma, and then how much of it comes into the urine per unit time. This is the clearance. How much is being cleared per unit time from the plasma. That's the clearance. Let's say this substance X. The equation is Ux into V upon Px, where well, let's write it here. Clearance of a substance X is equal to this. In this, Ux is urinary concentration of X in milligram per ml. That is, in every 1 ml of urine, how much substance? That's Ux. Okay, so that was the answer to the MCQ. Then V is, or rather we will take the other one. Px is plasma concentration of the substance X. And you know, plasma concentration of any substance is always taken as milligram percent or milligram per deciliter or milligram per 100 ml. Therefore, it will be milligram percent. And V is urine volume. Volume of urine per unit time, or also called as urine flow rate, and that will be ml per unit time. Let's take it per minute. It could be per hour, per day. So that's volume of urine or urine flow rate, right? Let's try to understand this further. Ux into V upon Px, that's the clearance of this substance. So what is Ux? Urinary concentration of the substance X in milligram per ml. Milligram per ml. Let's take some hypothetical values, arbitrary values. Let's say 2 milligram per ml. That's the urinary concentration of the substance. And total volume of urine, let's say 100 ml per minute. That's the urine flow rate per unit time. That means in this, the numerator would be, see, in every 1 ml of urine, 2 milligram substance is being excreted. That means in the 100 ml urine, how much will be excreted? 100 into 2, that's 200 milligrams, isn't it? In every 1 ml urine, 2 milligram substance is being excreted, that particular substance, X. So in 100 ml urine, how much? 200 milligram, 200 milligrams per minute. That would be the numerator, isn't it? That means the substance will be excreted at the rate of 200 milligrams every minute, right? Now that's clear. So that means it is the, let's write it down. What is the meaning of Ux into V? What is the meaning of numerator? Total excretion rate of the substance. It will be the total excretion rate of that substance in milligram per minute, or let's say per unit time. Excretion rate of that substance per unit time, per minute, per hour, per day, whatever unit we are taking, right? So I want you to keep this in mind as a concept. How do you calculate the total excretion rate of that substance per unit time? Is urinary concentration of that substance into total volume of urine, obviously. So that much will be the total excretion rate. That's how the substance is excreted every minute or every hour or every day. And what is the denominator? It's the plasma concentration of X. So finally we can say, what is clearance? Clearance is the ratio, actually. It's the ratio of, or ratio between total excretion rate of that substance per unit time to its plasma concentration, which is at the denominator, right? Okay. But then what you should note here is that the numerator and denominator, their units are not the same. Numerator is milligrams per minute and denominator is milligram percent. That should be noted clearly. So this is the ratio of total excretion rate of that substance per unit time to its plasma concentration, right? So simply speaking, this much was there in the plasma, this much concentration was there in the plasma, and from that this much is coming into the urine per unit time. That's in the numerator. So that's the ratio really, and that's the concept of clearance. Well, we will be requiring all this information throughout this chapter and maybe even later on in some other sections. So you must clearly understand all these units. Okay, That was clearance. Let's now talk about the glomerular filtration rate, GFR. Basically, we will be discussing two major aspects of it. Factors determining and influencing the GFR and measurement of GFR. These will be the two things which we will mainly discuss in this particular section. And what question has been asked on this particular section? For instance, in a patient suspected of renal failure, the creatinine clearance was found to be 135 ml per minute. Creatinine clearance in a patient was found to be 135 ml per minute. How much will be his GFR? And the options are 125 ml per minute, 130 ml per minute, 135 ml per minute, 140 ml per minute. You want to answer that just now? Okay, the answer is 130. Why? We will discuss it. Creatinine clearance is an overestimate of the actual GFR. So, we will see that in some time. Okay, and then the other simple questions, fact-based questions. For instance, the best substance to measure the GFR is, and the options are inulin, creatinine, PAH, mannitol. What is the best? Inulin? Yes. And the substance most commonly used actually to measure the GFR is, and take same four options, inulin, creatinine, PAH or mannitol. The answer this time would be creatinine. Why is that? We will see all this in the coming chapter, in this section. Okay, so let's start. First of all, glomerular filtration, this is just introduction. Glomerular filtration is called as ultrafiltration. Glomerular filtrate is an ultrafiltrate. Why? You know, the filtration which occurs under pressure is called as the ultrafiltrate. So glomerular filtration which is happening under pressure, the Starling's forces and the pressures, therefore it is the ultrafiltrate. And as you're already aware that afferent arteriole brings the blood into the glomerulus, which is a tuft of capillaries, and then the substances are filtered out and the remaining blood will go into the efferent arteriole. So let's first see the factors determining the GFR. Factors determining. We are talking about the Starling's forces, essentially the Starling's equilibrium or the Starling's forces involved in the filtration process. I want to just recall from the previous chapter, or you may just refer to the chapter where we have discussed these forces, that basically there are two pressures which are involved in the filtration of substances in and around the capillaries. One was capillary hydrostatic pressure and the other one was colloid oncotic pressure. We have done this already in the CVS. So these will be the and therefore if you remember, let me just draw it here. Let's say here is a capillary and any accumulated fluid exerts the hydrostatic pressure. So we have capillary hydrostatic pressure which will force the fluid out of the capillaries, but outside the capillaries there is interstitial fluid which is also an accumulated fluid, so it will exert interstitial fluid hydrostatic pressure which will force the fluid back into the capillaries. Remember, we have done this already, that hydrostatic pressure is a force that pushes the fluid away out of that compartment into the neighboring compartment. So capillary hydrostatic pressure will force the fluid out, it will cause the filtration out of the capillaries, and interstitial fluid hydrostatic pressure will force the fluid back into the capillaries. So it is an opposing force for filtration. Then we also have plasma colloid oncotic pressure or osmotic pressure. Here is a force which is exerted by the proteins. Colloid oncotic pressure is exerted by the proteins. Yes. So plasma proteins are exerting plasma colloid oncotic pressure, and here is a force that pulls the water towards it by osmosis. So plasma colloid oncotic pressure will pull the water or filtrate back into the capillaries, whereas in the interstitium there is interstitial fluid colloid oncotic pressure, because in most of the tissues, I'm not talking about the kidney here, okay, in most of the tissues the proteins do get filtered out into the interstitium, and therefore there will be proteins in the interstitial fluid, and they will exert what is called as interstitial fluid colloid oncotic pressure, and this force will pull the water towards it by osmosis, means out of the capillaries, means it will help in the filtration. This will be an additive factor for filtration. So that was the case in all other tissues. Let's apply these forces or pressures now in the glomerular capillaries in the context of GFR, glomerular filtration rate. There is one force that favors the filtration at the capillaries. The factor that favors the filtration at the glomerular capillaries, it is glomerular capillary hydrostatic pressure. And if you remember from the CVS chapter, I mean, you must refer to the CVS chapter because we have done this there in detail. We saw in that chapter that elsewhere in the body, the capillary hydrostatic pressure in all other tissues, it is about 15 to 20 mm of Hg. In the glomerular capillaries, it is 3 to 4 times that. So it will be 60 mm of Hg. Look, it is 60 to 75. Some authors also claim it to be 75. Let's say 60 mm of Hg is a force that favors the filtration. And then there are two forces or two pressures which oppose the filtration. Means they will tend to cause the movement back into the capillaries. What are those forces then? One is plasma colloid oncotic pressure. It is 32 mm of Hg. And the other one is, look, in the case of glomerulus, when the filtration happens, the fluid comes in the Bowman's capsule and the fluid accumulates here. So that fluid will exert Bowman's capsule hydrostatic pressure. And as we know already that the hydrostatic pressure is the force that pushes the fluid back into the capillaries. Fluid which is outside the capillaries, it has hydrostatic pressure and it will force the fluid back into the capillaries, right? So Bowman's capsule hydrostatic pressure is the force which is opposing the filtration because it is sending the fluid back into the capillaries. And this pressure is about 18 mm of Hg. So look at this and calculate how much is the total opposing force. it opposes the filtration. How much is the total opposing force? 32 plus 18, and that is 50 mm of Hg. By the way, you must have noted one point by now, that when we discuss the Starling's forces elsewhere in the body, in all other tissues, we talked about the 4 forces which are acting in and around the capillaries. And here there are only 3. Where is the 4th one? The interstitial fluid colloid oncotic pressure. That is missing here. There is no Bowman's capsule colloid oncotic pressure. And why is that? You got it. Yes, because proteins do not get filtered. Normally, proteins do not get filtered out of the capillaries or out of the glomerular capillaries. Elsewhere in the body, the proteins do come out of the capillaries. But in the glomerular capillaries, because of the negative charges on the basement membrane and because of the large size of the proteins do not get filtered out of the glomerular capillaries to come into the Bowman's capsule. So therefore, there is no Bowman's capsule colloid oncotic pressure. Okay, and therefore there are only 3 instead of 4. Right. Now coming to this, there is one factor that favors the filtration, and that is 60 mm of Hg, and there are 2 factors put together which oppose the filtration. If they are put together, it's 50 mm of Hg. So there is something called as net filtration pressure, also called as effective filtration pressure. Look, the favoring pressure is 60 and the opposing pressure is 50. Therefore, net filtration pressure that actually causes the filtration is plus 10 mm of Hg, which actually causes the filtration at the glomerulus. So that's the net or effective filtration pressure. Next point. What is capillary filtration coefficient? In the previous section, I mentioned this, that you will have to by heart it. Capillary filtration coefficient is the rate at which the capillaries filter out the fluids and the substances. In the case of glomerular capillaries, I had mentioned it that it is highest in the body, in the glomerular capillaries. It is 12.5 ml per minute per mm of Hg. Remember? Okay. That means for every 1 mm of Hg of net filtration pressure, in 1 minute, 12.5 ml filtrate will be formed. So then, how much is the net filtration pressure? 10 mm of Hg. So for 10 mm of Hg, how much filtrate will form every minute? 12.5 into 10. And that's 125 ml per minute. That is the normal GFR, 125 ml per minute, or 180 liters per day. If we convert minute into day, I mean this is per unit time, right? So that's the normal glomerular filtration rate. Let's also look at one more entity related to this, and that is filtration fraction. Filtration fraction. Look, you remember what is the renal blood flow? We have seen this already. The normal renal blood flow is about 25% of the cardiac output. So if we take cardiac output to be 5 liters per minute, 25% of 5 liters would be about 1250 ml per minute. That's the normal renal blood flow. But so far as the filtration is concerned, filtrate comes out of the plasma. Okay, this is whole blood, but filtrate comes out of the plasma. The glomerular filtrate which is being formed, it's formed out of the plasma. So therefore we have to know how much is the renal plasma flow, because filtration will form out of the plasma. Renal plasma flow obviously will be half of this, roughly. You know, the blood is made up of cells and plasma. So 45% roughly is the cells volume and 55% is plasma. So 55% of this, let's say it's in the range of 625 to 650 ml per minute. That's the renal plasma flow. So this much is plasma flowing through the kidneys every minute, and from this much plasma the glomerular filtrate is forming every minute. That's 125 ml per minute. And therefore, how much is the filtration fraction? Filtration fraction is GFR upon RPF. This much plasma flows through the kidney every minute, and from that this much is the filtrate which is formed every minute. So 125 upon let's say 625 ml per minute, and that is approximately roughly 1/5 or 20%. 20%. So from whatever plasma is flowing through the glomeruli, through the kidneys, only 20% will be filtered out, and that's the filtration fraction. So remember, a substance does not get totally filtered out in one pass. Only 20% will get filtered out. Okay, so that's filtration fraction. These are the things related to the GFR. Next point is factors influencing the GFR. How the GFR can change. So what we can do here is, we will take one factor and then we will say what happens to GFR if this happens, what will happen to the renal blood flow and renal plasma flow, and therefore what will happen to the filtration fraction. Filtration fraction, of course, is GFR upon RPF. Okay, so a first factor, dilation of the afferent arteriole. If the afferent arteriole dilates, that means more blood will come into the glomerulus. So renal blood flow will increase, renal plasma flow increases, but GFR will also increase. So more the blood coming into the glomerulus, more will be the filtration, and therefore increase GFR, increase renal blood flow, filtration fraction can remain more or less the same. Second, moderate constriction of the efferent arteriole. Just moderate constriction of the efferent arteriole. So let's have a diagram to visualize it. Here is the efferent arteriole. If it is constricted, what will happen to the blood flow and what will happen to the GFR? Look, first of all, renal blood flow will decrease and renal plasma flow will decrease, because blood flow is in per unit time, and if the blood going out per unit time decreases because of the constriction of the efferent arteriole, If the blood going out per unit time decreases, then the blood coming in per unit time will also decrease. And therefore, eventually the renal blood flow and renal plasma flow will decrease. When I say renal blood flow, actually we can take it as renal plasma flow, in the sense that we are talking about the rate of blood flow and rate of plasma flow. They will be the same. Now, yes, so renal blood flow will decrease in the efferent arteriole constriction. What about the GFR? GFR will increase. Why? Because the blood leaving the glomerulus now has become less. I mean, less blood leaving the glomerulus because of the constriction. That means more blood accumulates in the glomerular capillaries. And remember, capillary hydrostatic pressure, more the amount of blood or fluid accumulated, more will be the hydrostatic pressure. So, if more blood is accumulating in the glomerular capillaries, capillary hydrostatic pressure in the glomerulus will increase, right? So, there will be increased glomerular capillary hydrostatic pressure. And here is a force that favors the filtration. So, GFR will increase. Let's write it down. In the moderate constriction of efferent arteriole, GFR increases and renal blood flow and renal plasma flow decreases. So, numerator has increased, denominator has decreased. What will happen to the filtration fraction? Filtration fraction will increase. Right. Now there is a twist. Look at the third influencing factor. Severe and sustained constriction of efferent arteriole. Severe sustained constriction of the efferent arteriole. Now there is a change in the scenario. Look, if there is a severe and sustained constriction, what will happen is the plasma proteins which are there here in the capillaries, those plasma proteins are unable to leave the glomerular capillaries. That means plasma proteins will stay in the glomerular capillaries because it's a severe sustained constriction of the efferent arteriole. So plasma protein concentration will increase in the glomerular capillaries. What will be the result? There will be increased plasma colloid oncotic pressure in the glomerular capillaries. And remember, here is a force that opposes filtration. So that force increasing, that pressure increasing means GFR will eventually decrease. Remember this, there is a decreased GFR. And also the fact that initially when the constriction happened, when the efferent arteriole constricts, initially filtration rate had increased. So that means more fluid came into the Bowman's capsule because filtration rate had increased, and less fluid or less plasma is staying in the glomerular capillaries because filtrate is formed. More and more filtrate was formed. So less plasma in the glomerular capillaries. So capillary hydrostatic pressure in the glomerular capillaries, the glomerular capillary hydrostatic pressure will decrease because a lot of fluid has been filtered out. So less amount of blood in these capillaries over here, less amount of plasma, I mean to say, and the fluid got filtered out and came into the Bowman's capsule. So Bowman's capsule hydrostatic pressure will rise, increase, and that force is an opposing force. It will oppose the GFR. So the end result is there is a decreased GFR. And of course, there is decreased renal blood flow and renal plasma flow. because less blood going out means per unit time means less blood coming in per unit time, and overall blood flow will decrease. That we have already seen. Let's write down. GFR decreases, renal blood flow and renal plasma flow decreases. So filtration fraction more or less will remain the same. Right. Let's take one more factor influencing. Just for the sake of understanding, we will take a factor like a nephrolithiasis. Nephrolithiasis, renal stones. What do you think will happen to GFR? What do you think will happen to the renal blood flow and renal plasma flow? And therefore, what will happen to the filtration fraction? So here it is. In nephrolithiasis, what happens is those crystals, the renal stones or the crystals, they will decrease the flow of tubular fluids. They will decrease the flow of tubular fluids. Okay. Which means what? Which means more and more filtrate will stay in the Bowman's capsule because it is not flowing down normally into the tubules. There is decreased flow of tubular fluids. So, more and more fluid, more and more filtrate stays in the Bowman's capsule. That means there is increased hydrostatic pressure in the Bowman's capsule. And now there is needless to say that here is a force that opposes the filtration. Therefore, GFR will decrease. So remember, in the nephrolithiasis, glomerular filtration rate will decrease. Renal plasma flow and renal blood flow is unaffected by the nephrolithiasis, and therefore filtration fraction would decrease. This ratio or the filtration fraction will decrease. Let's just write down here. Nephrolithiasis, GFR decreases, renal blood flow and plasma flow more or less the same. So filtration fraction decreases. These are some of the important factors. They can give you a case study or some problem and ask you to calculate what will happen in this particular case. So, for instance, they can give you to calculate filtration fraction by giving you the other two, or net filtration pressure. They will ask you to calculate. In fact, very often that question has come in INI CETs, the net filtration pressure to calculate. That was about some of the factors determining and influencing the GFR. Now let's see measurement of the GFR. Well, measurement of the GFR. Best substance that we can use to measure the GFR is inulin. And why is that? Look, inulin is a fructopolysaccharide, a polymer of glucose. And inulin is not generated in the body. It has to be injected. When we inject the inulin, what happens is we are looking at such a substance for measurement of GFR is that it will have these properties, that it will be freely filtered at the glomerulus. First property. It should be freely filtered at the glomerulus, like plasma, freely filtered at the glomerulus. But that means it should not be bound to proteins. This substance which we are going to use, it should not be plasma protein bound. So it will get freely filtered at the glomerulus. And the second one, that it should neither be reabsorbed nor secreted by the tubules. Okay, that's another property. So imagine this substance gets freely filtered at the glomerulus, and then it's neither reabsorbed nor secreted by the tubules. That means whatever was filtered, all of it will come into the urine per unit time. The substance filtered per unit time at the glomerulus will be equal to substance excreted per unit time, isn't it? That means its excretion rate, the substance excretion rate, will give you its filtration rate at the glomerulus, isn't it? And that will give you the idea of GFR, right? So its filtered mass of that substance will be equal to excretion of X. Excreted mass, filtered amount of X per unit time will be equal to excreted amount of X per unit time. So therefore, and since it is getting freely filtered at the glomerulus, it gives us the idea about glomerular filtration rate. These are the properties, and these properties are observed by inulin. And therefore, inulin is the best for measurement of GFR. Right. But inulin has got a problem. Inulin is not generated in the body. It's not a metabolic end product or something. And inulin, maybe when injected, many people may be allergic to inulin. And therefore, we need some endogenous substance. Therefore, most commonly used substance for measurement of GFR is creatinine. Creatinine is endogenously generated. It does not have to be injected, so no worries there. Muscle has creatine, and from that creatinine forms, and it's an excretory product. It will be excreted into the urine. 24-hour sample has to be collected for creatinine levels. So best is inulin, but most commonly used is creatinine. Now why is there are some fallacies, some error is possible with creatinine. Let's see that. I had asked you the MCQ. A patient had creatinine clearance of 135 ml per minute. Then how much will be the actual GFR? Its creatinine clearance is an overestimate of GFR. It overestimates the GFR by about let's say 5 to 10%. So if I were to roughly calculate, you know, the values that were given in the MCQs was 125 ml per minute, 130 ml per minute, 135 ml per minute, 140 ml per minute. So if the creatinine clearance is 135 ml per minute and it's an overestimate of GFR, then actual GFR would be less than that and about 130 ml per minute. That was the answer. Now the question is, why is it that the creatinine clearance is an overestimate of the GFR? Let's see. First thing is, creatinine is freely filtered at the glomerulus. So no issues there. Okay. But the urinary excretion rate of creatinine, let's say urinary creatinine concentration or urinary excretion rate, let's just correct the unit. The excretion rate of creatinine per unit time is, it will overestimate the GFR. Excretion rate of creatinine overestimates the GFR by about 15 to 20%. You know why? Because the creatinine that is appearing in the urine, some of it has come from tubular secretion. So 15 to 20% creatinine coming into the urine comes by tubular secretion. So urinary excretion rate, whatever is coming into the urine, is not totally reflective only of the filtration of creatinine. 15 to 20% is coming into the urine by tubular secretion. Right. So creatinine clearance, let's write it down here. Creatinine clearance, UV upon P. Remember the formula, U into V upon P. Now we have seen that the numerator, that is urinary excretion rate of creatinine, is a false overestimate. It's a false overestimate of GFR by about 15 to 20%. I need to tell you the second factor in this equation, that is plasma concentration of creatinine. So listen to me carefully. Plasma creatinine concentration, which is the numerator, which is the denominator in the equation. Plasma creatinine also is a false overestimate. The plasma creatinine value is also a false overestimate by about 5 to 10%. Why is that? That's because of the so-called Jaffe reaction, named after William Jaffe. Jaffe reaction. You know, we measure the creatinine by standard colorimetric analysis. Colorimetric. So what happens is, when we are measuring the plasma creatinine, there are some non-specific chromogens in the plasma. Non-specific chromogens. They get added in this creatinine measurement to give us a falsely high value of plasma creatinine. You understand this? We are measuring plasma creatinine, which is at the denominator, but we don't get the absolutely correct value. We get a false overestimate of plasma creatinine because we are going to measure the plasma creatinine by the colorimetric methods, and there are some non-specific chromogens in the plasma that get added along with the creatinine to give us a falsely high value of the plasma creatinine. So now you can see that in the creatinine clearance equation, numerator is overestimated by about 15 to 20%, but denominator also is a false overestimate by about 5 to 10%, and therefore these values, these errors tend to cancel out to some extent, and therefore finally, as I mentioned, that the creatinine clearance is an overestimate of the actual GFR by about 5 to 10%, because numerator was overestimated by 15 to 20%, denominator was overestimated also by about 5 to 10% or 10% or so, and therefore finally by the equation, if those errors cancel out, they are in the same direction, and therefore that's the point. So remember, this creatinine clearance is a overestimate of the actual GFR. The point that you had to understand and keep in mind is that some amount of creatinine is coming by tubular secretion. We were all interested only in the filtered amount, but tubular secretion is giving us that extra creatinine in the urine, and therefore it becomes a false overestimate of the actual GFR. Right, so that was the discussion on GFR. Let me just also add a small section on measurement of renal blood flow or renal plasma flow. What is the ideal substance to measure the renal plasma flow? Ideal substance to measure the renal plasma flow or renal blood flow is para-amino hippuric acid. Hippuric acid, PAH. This is ideal or commonly used substance to measure the renal blood flow and renal plasma flow. Let's try to understand why. It's a concept again, and I think at the start of the previous section I had asked one question. It was a sample question that in a patient renal blood flow was to be measured. So technician was going to give PAH, but the technician made some wrong calculation and gave thrice the recommended dose. 3 times high dose of PAH was injected wrongly in the patient while measuring the renal blood flow. So what will be the effect of this wrong calculation on the measurement of renal blood flow? The options are falsely high renal blood flow will be measured, or no error will occur, or falsely low renal blood flow will be measured, or depends on the renal blood flow itself. These are the options. So it is a problem solving type of MCQ, and as I've mentioned at the start, now most of the MCQs are going to be like this: the case based or problem solving type, analytical type. Okay, so let's understand why the PAH is the ideal substance to measure the renal blood flow and renal plasma flow. First thing is that if you just recall our discussion on cardiac output measurement, there is a fixed method and a fixed equation for measurement of blood flow to an organ and measurement of the cardiac output. After all, what is cardiac output? Addition of blood flow to all organs will be equal to cardiac output. So same method or same principle and equation can be used for measurement of cardiac output or measurement of blood flow to an organ. So if you remember, we had said cardiac output is equal to oxygen consumption ml per minute by the entire body upon arteriovenous oxygen difference in ml. Okay, you can refer to the section cardiac output once again. Now coming to the blood flow to an organ, same equation can be used. First of all, we are talking about the renal blood flow, so let's write it here, renal blood flow. We don't use oxygen. Instead, we will inject a substance X, and the equation will become something like this. See, we are measuring the renal blood flow, so numerator will be, instead of oxygen consumption, it will be consumption of X by the kidney ml per minute. See, for the cardiac output it was oxygen consumption by the entire body, but here it's the blood flow to the kidney, so consumption of X by the kidney ml per minute, and denominator was arteriovenous oxygen difference. We are not using oxygen, we are injecting a substance X to measure the renal blood flow. So arteriovenous difference of X in the kidney, we can write it like this: renal artery concentration of X minus renal venous concentration of X. Therefore, we need a substance X to be injected and it will give us the renal blood flow from this equation. Let's look at these three parameters. Numerator has one parameter and denominator renal artery concentration, renal venous concentration. Let's look at them one by one. First, numerator. Consumption of X by the kidney per unit time. Look, I am trying to tell you the criteria why we use PAH. Okay, why is PAH is the chosen one to measure the renal blood flow? We are trying to see what's the criteria for that. So let's first see those three things. Numerator is what? Consumption of X by the kidney per unit time. Now, we want such a substance that is consumed by the kidney entirely. But consume means what? Consume means there are many things by which we can mean consumption. See, an organ can metabolize that substance. That's also a way of consumption of that substance. We want such a substance X which is consumed by the kidney but not by metabolism. Then how? But by urinary excretion. We are looking at such a substance X which should be consumed by the kidney but not by metabolism. Kidney should not metabolize it. Then kidneys should excrete it into the urine. Consumed means excreted out of the body, excreted by the kidneys. So that should be one property in that substance X. In that case, if that is the property which is followed by X, in that case, numerator will be in this fixed equation, numerator consumption of X by the kidney per unit time will be same as its urinary excretion rate, because the substance is being consumed by the kidney by excreting it out into the urine. Okay, so consumption of X by the kidney will be same as its urinary excretion rate. Now please recall, how do you calculate urinary excretion rate of a substance per unit time? Come on, recall it. We said this some time back. Total excretion rate of a substance is equal to Ux into V. Urinary concentration of the substance into total volume of urine. That will be the total excretion rate of that substance. So kidneys consume that substance, means they excrete it into the urine, excrete that substance into the urine. So the total consumption by the kidney, total consumption of X by the kidney will be same as its total excretion rate into the urine, and total excretion rate is calculated like this. We have done that already. Now come to the denominator. Renal artery concentration will be required, renal venous concentration will be required. Let's take renal artery concentration, and there is a second criteria for X. Look, accessing the renal artery to collect the sample for the concentration of X, that's a very tough task. Renal artery is not so easily accessible. So we have another criteria, that is X, this substance X should not be handled by any other organ except kidney. Mark these words. The substance X should be such a substance, that's the criteria number 2, should be such a substance that apart from kidney, no other organ handles it. It is not handled by any other organ except kidney. In that case, renal artery concentration of X will be same as systemic plasma concentration of X. Isn't it very obvious? I mean, whatever is there in the systemic artery or systemic plasma, all of it is coming into the renal artery because it is not going in any other organ. No other organ is handling that substance. So whatever is there in the systemic artery, all of it as such, same concentration will be found in the renal artery. Simple. So in that case, renal artery concentration of X will be same as systemic plasma concentration of X. That means we don't have to go to the renal artery to collect the sample for concentration of X. We can simply collect from its systemic circulation. It will be same as the plasma concentration, right? So denominator, renal artery concentration will be same as plasma concentration of X. So sample collection will be easy. We just have to collect the plasma, and see the concentration of the X. Third criteria, in the fixed equation, we also want renal venous concentration of X. Now, even accessing the renal vein is very difficult, impossible. I mean, it's very tough to access the renal vein and then collect the sample for the concentration of X. So, we come to the third criteria. The third criteria means, what if the substance does not come in the renal vein at all? Means what? Then we don't have to access the renal vein to collect the sample for the concentration of X, isn't it? Because it does not come in the renal vein at all. So that the criteria number 3 is renal vein concentration of X is equal to 0. It does not come in the renal vein at all. But, which means what? Which means this substance is completely removed by the kidney in a single pass. Completely removed by the kidney in a single pass. What I mean to say is, and this is the most important criteria, once it comes into the renal blood, renal artery and renal circulation, then by filtration and by tubular secretion, it is 100% completely excreted into the urine in a single pass. Okay, that means then nothing will go in the renal vein. All of it has come into the urine completely. So its renal venous concentration is 0. And therefore we don't have to go to renal vein to collect the sample because it does not go in the renal vein at all. Right? So if you look at the equation now, renal venous concentration should be 0. Now you can look at the equation. We started with the fixed equation for the measurement of blood flow to an organ. But if that substance X follows these 3 criteria, then the same equation now has become what? UV upon P. Clearance of that substance. It has become the clearance of that substance. So, renal blood flow will be equal to clearance of that substance. Means what? Means if we know the plasma concentration of that substance and if we know the urinary excretion rate of that substance, we will know the renal blood flow and renal plasma flow, right? And finding out these two is easy. Urinary excretion rate of the substance and plasma concentration of the substance. So if the substance follows these 3 criteria, then its clearance will be same as renal plasma flow and renal blood flow. Well, I am using the terms plasma flow and blood flow interchangeably only because we are looking at the rate of flow. Okay, so blood flow and plasma flow will have the same rate per unit time. Okay, now renal blood flow is calculated by the clearance of this substance. Okay, most important criteria is the third one. Even if you forget the first two criteria, third criteria is the most important one. I mean, a substance coming into the renal blood, then by filtration and secretion, all of it comes into the urine per unit time. So its urinary excretion rate will give you the renal blood flow rate at the kidney, isn't it? So that's why the third criteria, that it is completely removed by the kidney in a single pass. Then its urinary excretion rate will give you the blood flow rate in the kidney. It comes into the renal blood, then it comes into the urine. All of it comes into the urine. So its excretion rate gives you the blood flow per unit time. Right. And therefore, let's write it down that PAH clearance is equal to renal blood flow and renal plasma flow. Now let's come to the question. Thrice the recommended dose of PAH was given. Let's write it down. PAH clearance is UV upon P. Okay. And the other thing that I must mention here at this stage is that once the PAH comes into the renal blood, then all of it comes into the urine in a single pass. Okay, it does not go in the renal vein at all. That means there are two processes which are causing the excretion: glomerular filtration and tubular secretion. So by glomerular filtration and tubular secretion, all of it will come into the urine. That's the point. But you remember what is the filtration fraction? Come on, what is the filtration fraction? 20%. So a substance can come into the urine, or a substance that gets filtered at the glomerulus, it does not get completely filtered. 20% fraction gets filtered at the glomerulus. So even for PAH, that is applicable because filtration fraction is 20%. At any given one pass, 20% of the fraction gets filtered of the plasma, and therefore of the PAH which is present in the plasma, 20% fraction will get filtered, but all of it should come into the urine in a single pass. So what about the remaining 80%? Remaining 80% comes by tubular secretion. You get the point? Plasma filtration fraction is 20%. So only 20% of the PAH will get filtered at the glomerulus, and 80% will come by tubular secretion, so that all the 100% will come into the urine in a single pass. It will not go into the renal vein at all. Right. So major chunk of excretion of PAH is coming by tubular secretion. With that in mind, now let's see the question. The technician gave thrice the recommended dose of PAH. Generally, 20 milligram per deciliter is the value of PAH after it is injected for the measurement of renal plasma flow. Now, if you have given wrongly high dose of PAH, that means its plasma concentration will increase. After all, PAH was injected into the plasma, into the blood. So, plasma concentration of PAH will increase when you gave thrice the recommended dose, wrongly, erroneously. But then, initially, what happens is, suppose let's come to the let's go step by step. First, technician gave twice the recommended dose. by mistake, by wrong calculation, he gave twice the recommended dose. So plasma level increased. Then what about the numerator? Numerator is total excretion rate. That also can increase. You know why? Because 80% of PAH coming into the urine is coming by tubular secretion. And now I'm making a very important statement. Listen to this. For tubular secretion or for tubular reabsorption, what do we need? We need carrier proteins. There is a carrier protein for secretion or reabsorption also. We are not interested in reabsorption right now. Here, for secretion of PAH, there is a carrier protein. And you know, we have increased the plasma concentration of PAH and it is being secreted into the tubule by this carrier. Now, if you go back to our chapter on the carrier mediated transport, that is a facilitated diffusion, the graph for facilitated diffusion was something like this. This is the rate of transport, and on this axis we have concentration of the substance on one side of the membrane. See, carrier is transporting the substance from one side of the membrane to the other side. So concentration of substance on one side of the membrane. What we saw in this graph is that if you go on increasing the concentration of the substance on one side, the rate of transport also increases initially. Yeah, the graph is going up. And then later on, you increase the concentration further. Carrier gets saturated. So beyond this point, you increase the concentration further, carrier has got saturated. So rate of transport will not increase any further. The graph will not go any further. Whatever is that maximum was reached, that maximum will stay. Carrier will just deliver the substance at that maximum rate because the carrier is completely saturated at that particular concentration. So if we increase the concentration of PAH in the plasma, let's say twice the recommended concentration was injected wrongly into the plasma. That means carrier will also increase its rate of transport. This is a PAH carrier. It is secreting the PAH into the tubule. It can increase the rate of PAH secretion because plasma concentration has increased. Concentration of the substance has increased on one side of the membrane. That's how means to understand. So if you gave twice the recommended dose of PAH by mistake, by wrong calculation, its plasma concentration will increase and proportionately its urinary excretion rate, numerator, will also increase proportionately because carrier is secreting more and more PAH and it will come into the urine. That means the PAH clearance will remain the same, will remain normal. And PAH clearance means what? Renal plasma flow. So renal plasma flow also will not give, there will be no error in the renal plasma flow measurement. Now, thrice the recommended dose. You know, it has been observed that let's say normal plasma concentration 20 milligram per deciliter and twice the recommended dose increased it up to 40 milligram per deciliter. It has been observed that the PAH carriers get saturated if this is a PAH carrier, it gets saturated if the pH concentration reaches 60 milligram per deciliter. So three times high. What happens if you gave thrice the recommended dose of PAH by mistake? Plasma concentration increased by 3 times wrongly, erroneously. Now what happens is the carrier gets saturated. So carrier now cannot increase the rate of secretion anymore. That means after a certain increase in the urinary excretion rate, because secretion rate was increased, now the secretion rate will reach the peak and it will remain constant. So numerator at certain stage will remain constant because carrier has got saturated, and denominator has increased. That means now the pH clearance will decrease slightly. pH clearance will come lower. Why is that? Because numerator after reaching certain point has become stagnated. It cannot increase any further. pH excretion rate cannot increase any further. Why? Because carrier has got saturated and the plasma concentration is increasing. So eventually pH clearance will now become lower by this equation, and pH clearance is the same as renal plasma flow. So that means erroneously low renal plasma flow will be estimated. Okay, that's the answer to the MCQ. So please you can go through the video again just to have this concept imbibed correctly. The most important part in this were two sentences. One is PAH completely comes into the urine. Once it is injected into the blood, then all of it comes into the urine in a single pass through the kidney. It does not go in the renal vein at all. That was one important statement. And the second one was 80% of the PAH which is coming into the urine is coming by tubular secretion. That's the second important statement. And tubular secretion requires carrier, and carrier can get saturated. Then it cannot increase the excretion rate of PAH. That was the second important statement. All right. Since renal blood flow and renal plasma flow go in the same direction, hand in hand. If the renal blood flow increases, renal plasma flow increases. So therefore, I was using the terms interchangeably so far. Okay, renal blood flow, renal plasma flow. But there is a difference, as you know. So if we get the renal plasma flow by PAH clearance, and then we calculate the renal blood flow, that's the actual position. So renal plasma flow we will obtain. Obviously, because PAH is getting filtered at the glomerulus. Whole blood does not get filtered. No, it's a plasma that gets filtered at the glomerulus. So naturally, PAH is going to first give us the renal plasma flow. And then we calculate the renal blood flow from it. So renal blood flow is equal to, this is the formula, renal plasma flow, which we obtained from PAH clearance, into 1/1 minus hematocrit. You know what is the difference between the whole blood and the plasma? The hematocrit, value of hematocrit is the difference. No? Plasma plus hematocrit is whole blood. So we'll have to consider the hematocrit into the equation. That's the equation. That's how you calculate renal blood flow from the renal plasma flow. One more thing, there is something called as, yes, listen to this part also. There is something called as effective renal blood flow or effective renal plasma flow. What is that? Look, once you obtain this by PAH clearance, you know, we will have to take 90% of that value. Why is that? Why don't we take the entire value? Because out of the total blood flow, some 10% blood flow goes in the non-excretory part of the nephron, or non-excretory part of the kidney rather, like a perinephric fat or some tissue which is not involved in the excretion of substances. So even PAH is not going into the nephrons all 100%. Some 10% is going in the perinephric fat. So whatever we get, actually that PAH clearance would be 90% of what it could have been if all 100% blood was going into the excretory part of the kidney. Do you understand this? I'll repeat once again. I think I've made it complicated. Let me make it simple. Look, if all the 100% of blood was going into the nephrons and PAH was excreting into the urine, imagine that. And now imagine this, that actually 10% of the blood going in the kidneys is not going in the nephrons for the sake of excretion. It is going in the perinephric fat or the other tissue which is not involved in the excretion of substances. So we have that 10% extra blood which is not causing PAH excretion into the urine. So we are only getting 90% because that 90% blood went through the nephron and PAH came into the urine. And therefore there is something called as effective renal plasma flow, which we are getting in this case 90% of the actual renal plasma flow. Okay, these concepts, if you have never heard them before, I know it will be difficult to understand in the first instance. So you will have to, think about them again or watch the video again to understand these concepts. Okay, I'll take one more small section and then we will move on to the next section, tubular functions. Last point in this particular section is there is a substance X. Now this is again problem solving type of MCQ or problem based question. There is a substance X. Its urinary concentration is given to you. Its plasma concentration is given to you. Urine flow rate or volume of urine is given and GFR is given. And they are asking from the calculation, what is your opinion, whether the substance was secreted or the substance was reabsorbed, and such options are given. From they are giving the values and then we have to calculate what happened to this substance. Okay, listen to this. Make two brackets. If you see such a question, make two brackets. In the first bracket, you will write Px into GFR. This is total filtered amount of X per unit time. Total filtered amount of X per unit time, per minute. So first thing that is new in this particular thing is, if we want to calculate total filtration rate of a substance, total filtered amount of a substance at the glomerulus per unit time, how do you calculate it? Plasma concentration of the substance into GFR. This is the total filtered amount of a substance at the glomerulus per unit time. I'll give you an example. I'll write it here. Just an example. How much amount of bicarbonate gets filtered every day at the glomerulus? Plasma bicarbonate concentration is 24 milliequivalents per liter. That's the plasma concentration. And the GFR is 125 ml per minute. That is, we will have to take it into the liters. 180 liters per day. That's the GFR. Yeah, we saw that. 125 ml per minute, same as 180 liters per day. So, the total filtered amount of the bicarbonate will be 24 into 180. See? And the amount is 4320 milliequivalents per day. This is the total filtered bicarbonate every day. Therefore, you please remember this. How do you calculate the total filtered amount of a substance per unit time? It could be per minute or per day or per hour. Plasma concentration of the substance into the GFR. Now come to the second bracket. Okay, these two things are gone. we are left with this and this, ux into v. So let me write it in the second bracket, ux into v. Come on, now we have done it a number of times. What is ux into v? Total excretion rate of that substance will be ux into v, total excreted amount. Total excreted amount of X per unit time. So that's it. Now it will be easy. Just look at it and tell me. Just they have given the values and you are calculating. Now come on, tell me. If I say that first bracket is larger than the second, first bracket is larger than the second, what will you say? Meaning filtered amount is more and excreted amount is less than that. That means what? Yes, that's right. That means the substance was reabsorbed, isn't it? More was filtered, but less came into the urine. That means some amount was reabsorbed. On the other hand, if I say Px into GFR is less than Ux into V, what will you say then? Let me write the first one. This means the substance was reabsorbed, and if the filtered amount is less and more than that is coming into the urine, it means what? Some amount came by tubular secretion. Substance was added by tubular secretion, so more came into the urine than what was filtered, right? So this will mean the substance was secreted at the tubule. So this is how you can calculate. You must have understood by now that for any such question, you need to have that little background concept. Then you can solve easily.